Okay. Good morning, afternoon, evening, depending on where you all are. Welcome to this International Data Linkage Conference session on child protection. We've got 4 interesting presentations for you, which will take 10 minutes each, and then we've got some 15 minutes or so for questions after that. So I feel free to record your questions as we go. So our first presentation is from Rachel Pearson. She's with University College London, and she's looking at the use of administrative health and family court data to examine mental health need among women whose children enter care. So thank you, Rachel.
Sorry, I forgot to unmute myself. Hi, everyone. My name's Rachel Pearson, and today I'm going to talk about a linkage of family court records to electronic mental health care records for women who are involved in care proceedings involving children, concerning the placement of them into state care. And in England, these proceedings are often referred to as care proceedings, so I'll be talking about them as care proceedings. And a bit of background. So over the past decade in England, the rate of children involved in care proceedings has increased by about 70%. So a really quite huge amount, and approximately 16,000 and 17,000 women are involved in proceedings concerning their children each year. So these proceedings and sort of all child protection procedures in England and in most places are chiefly driven by child maltreatment. And it's well known that parental mental health and substance misuse are key risk factors for child maltreatment and therefore for entry into care and involvement in care proceedings. However, in England, we know very little about the mental health needs of parents whose children are enter care or involved in care proceedings, and how they use services. And so better information about this could help to inform improved responses to parental mental health care need in the context of child protection in England. So there's no one data set in England that involves data on care proceedings and child protection outcomes and data on parental health. So a linkage between mental health care records and family court data could inform improved approaches to responding to parental healthcare needs and other sort of preventative services. So we sought to link data for women involved in care proceedings who are known to mental health services to establish a linked data resource for both us and other researchers. So the data in care proceedings comes from CAFCAS, who are the Children and Family Court and Advisory and Support Service. So children involved in care proceedings are represented in tandem. So they're represented by a legal representative such as a barrister, and they're also represented by a specialist social worker known as the CAFCAS Children's Guardian. And the CAFCAS Children's Guardian has the role of ensuring that any decisions made by the family court are in the best interests of the child. And so as part of their duties, they record information on all individuals who are involved in care proceedings, so adults and children, in their case management system. And this includes relationships between adults and children, so you can see parent-child relationships. And they also give each individual a unique identifier in the data known as the CAFCAS person ID, so we can follow both family groups and individuals through the data in time. So for example, if a parent returns to court and for sort of subsequent sets of care proceedings. And then the data on mental health care records comes from the South London and Maudsley NHS Foundation Trust, and they're often known as SLAM, so I'll be referring to them as SLAM. And SLAM deliver, well, they're the sole providers of mental health services to 4 London local authorities. So those are the blue ones in that map, which are Croydon, Lambeth, Lewisham and Southwark. But they also deliver services in 4 neighbouring local authorities, so Bexley, Bromley, Greenwich and Wandsworth, which is the green ones on the map. So to maximise the size of the linked cohort, we link data for women involved in care proceedings in all 8 of these local authorities. So SLAM deliver a really broad range of mental health services, from perinatal services to other specialist services such as forensic and services and addiction services. But they also offer the IAP service, which allows self-referral to psychological therapies for people who experience common mental health disorders, so anxiety, stress, and depression disorders. And so SLAM has stored all of its service user records in its CRIS database since 2007, and again assigns all individuals a unique identifier called the BRCID. And it's really interesting data because it not only includes structured fields, but it also includes sort of free text fields that have been de-identified, so clinician notes and correspondence between clinicians and other organisations. And so researchers at SLAM have used natural language processing applications to extract information such as diagnoses from these free text fields to get a clearer picture on mental health needs from this data set. And they also have a clinical data linkage service. So SLAM were the ones that conducted this linkage. So we used a deterministic linkage algorithm that had 8 different steps, where the first step was the kind of least lenient, and the 8th step was the most lenient. And we also used soundex codes to kind of try to account for any differences in spellings or misspellings between the 2 different data sets. And so there are about 5,500 women involved in care proceedings in those 8 South London local authorities that SLAM provides either all or some mental health services to between 2007 and 2019, and about half of these women linked to the SLAM service user record. So we did some manual review of the most lenient link step, and also where more than one CAFCAS person ID matched to the same BRCID to remove, identify and remove some false matches and some duplicates, but these were very minimal, and the linkage rate or the match rate remained stable after that. And SAM has a different electronic patient record system for its IAP services. So we were also able to see how many women were using sort of the core main SLAM services, which typically have much higher clinical thresholds for referral and don't allow self-referral. So with 90% of women linking to these kind of services, it kind of indicated there was kind of a quite severe mental health need amongst this group. So to get a clearer picture on the prevalence of SLAM service use amongst women involved in care proceedings in South London, we restricted the cohort to just the 4 local authorities who were involved in, the women who are involved in care proceedings in those 4 local authorities where SLAM solely delivers mental health services. So they're the only provider of secondary and tertiary mental health services. And in those local authorities, the match rate was much higher, ranging from 62% to 72%. But what we also found was that in the unlinked group, there were quite a lot of women who had missingness amongst quite key identifiers in the linkage. So I think we can be quite confident that the true prevalence of SLAM service use amongst this group is probably a bit higher, although it's really hard to know how much higher. We also looked at how many women who linked were known to SLAM services before their first recorded set of care proceedings. And we found that 80% of women were, which kind of indicates a high prevalence of pre-existing or concurrent mental health need at the time of their care proceedings. So then we looked at who linked and who didn't link using the same cohort, so of those women involved in those 4 local authorities where services are solely delivered by SLAM. And we used a multivariable logistic regression to kind of identify any socio-demographic and care proceeding characteristics that are associated with higher or lower odds of linking to a SLAM service user record using the CAFCAS data, so the data we have available on all the cohort. So kind of some obvious things that we found were that women who had poorer recording of their identifiers, so unknown name, unknown age, unknown address, unknown ethnicity, were less likely to link or had lower odds of linking to a SLAM service user record. We also found that, that Black women and women of other ethnicity were less likely to link than white women. And sort of some hypotheses for why this might be. We know, particularly in South London, that there are systemic barriers that affect people from Black and other minority ethnic communities from accessing mental health services. We also know from other English administrative data that that erroneous recording of person identifiers is more common amongst Black and mixed heritage and Asian ethnicities compared to white ethnicities. In terms of higher odds of linkage, we found that women who had a young child, so an infant involved in proceedings, were more likely to link or had higher odds of linking. And again, we hypothesised that this might be due to strong referral pathways between children's social care services and SLAM's perinatal services, which involve the mother-baby unit. So kind of the implications of this work. So clearly we've demonstrated the feasibility of linking the CAFCAS data for multi-sectoral research. And the high linkage rate really emphasises that there's a high burden of mental health need amongst this population. And really raises the question of whether timely access to specialist mental health services should be a routine offer for women who are involved in care proceeding processes, and also really highlights the need for that post-proceeding support, which currently is only available via voluntary organisations in England and not in all local authorities. So it's kind of a postcode lottery for that kind of support. In terms of research, also we've shown that we've got a big data set for research that can be used not only by us, but also by other researchers. And in the future, research could even expand this linkage to include fathers. So obviously we focused on mothers because it was really complex set of permissions that we had to get to establish this. And so we're doing a lot of work, obviously, to inform strategies that we hope can prevent and respond to this kind of considerable mental health need amongst this group. So I just want to say thank you for listening, and just to highlight, this was a massive collaboration between people at UCL, at Lancaster University, and of course at SLAM and CAFCAS. And we're really grateful for everyone who took part in our public engagement work around this piece of research.
Right, thank you, Rachel. Now our next speaker is Vincent Hay from the Menzies School of Health Research in Northern Territory. I presume that's where, yes. And he'll be talking about the link between early involvement with child protection and youth offending. Thank you, Vincent.
Hi, everyone. I would like to first acknowledge the traditional owners of the land and pay my respect to the elders of the past, present, and the future. So this study is funded by the following 7 agencies of the NT government, and the views does not necessarily reflect that of the agency. So I will now talk about the rationale of this research. Over the past 20 years, there have been a growing call to move from a model that focuses on crisis management to a model that focuses on primary prevention and early support in childhood. This call is being supported by a vast literature that shows the link between child maltreatment and youth offending. However, one of the research gaps is this study does not provide a comprehensive whole of population perspective. They either focus on children who had contact with the child protection and or those children that have contact with the youth justice system, while others study youth sample in the general population. That's why there's a need for a whole of population perspective. This is important from the perspective of a public health approach. Under the Australian public health approach to child protection, it recognizes the needs that every child have different needs and risks involved. So this is important for a targeted prevention, ranging from primary prevention to tertiary prevention, such as out-of-home care. So in devising this prevention strategy, we need a whole of population perspective, and also the importance of interagency collaboration between the federal and the state government, as well as the non-government organization. Recently in 2020, Australia have a national agreement on closing the gap. Out of these 16 targets, 4 are related to child protection, the justice system, and household safety. So this study is being conducted in the Northern Territory, we've had the issue of overrepresentation of Aboriginal children in both the child protection and youth justice system. Although Aboriginal children comprise of 44% of all NT children, they comprise 87% of NT children in out-of-home care and 96% in the youth detention center. So in 2016 to 17, we have the Child Royal Commission into the protection and detention of Northern Territory children. That's when Menzies, our data linkage team, have provided 2 submissions to the Royal Commission. The first submission, we demonstrate using our linked data that for the Aboriginal population in the Northern Territory, 1 in 2 children will have a contact with child protection before age 10. And 1 in 4 have child protection substantiation, and 1 in 12 Aboriginal children will have out-of-home care before age 10. Whereas for non-Aboriginal children, the rates are 1 in 5 for notification, 1 in 20 substantiation, and for out-of-home care is 1 in 50 non-Aboriginal children. We have also made the second input for the submission, of which 1 key finding is amongst the Aboriginal children that have been found proven guilty, 3/4 have a prior record of child protection contact. So in this leads us to what we are doing now, because since 2009, our data linkage team have worked with different government agencies so as to build a common data platform that receives data from different government departments in the hope that we can use this to inform policy. So from this, what we are currently working and progress is we have data ranging from health, education, as well as social, and we will probably receive these different data sets soon. So now we'll talk about how we are going to conduct our study. So the aim of this study is to investigate the sex-specific association between the level and timing of child protection system contact and youth justice contact. So this is a retrospective cohort study of 10,000, almost 10,500 Aboriginal children that are born in the NT. In this study, we have linked 3 key data sets. They are mainly the NT perinatal register data set, child protection, as well as the NT justice court data set. So in analyzing this outcome, we have adopted a survival analysis, in particular a flexible parametric survival model. And the outcome measure is the first lifetime first alleged offense being charged for the offense when aged 10 to 17. In Australia, the minimum age of criminal responsibility is age 10. So this is when children first enter the reset, and the upper limit is age 17. So our exposure variable, we are interested in 2 exposure variables. The first is the level of contact of child protection system before age 10, and the second is timing of contact with the child protection system before age 10. So either it's early childhood from 0 to 4 or middle childhood from 5 to 9 years old. So this is the result of the first research question. So we first investigate among our cohort of Aboriginal children. So starting from age 10 to age 18, we have stratified analysis by gender, boys and girls. So in this, we first derive a cumulative incidence of first alleged offense. As you can see, there is a gradient of risk between the different level of contact with the child protection before age 10. And we can see that for both boys and girls, there are relative high risk of youth offense, first least youth offense for those that have been through the out-of-home care system before age 10. So for boys, in terms of cumulative incidence, by the age of 18, for those boys that have been in the out-of-home care system, almost 45% will have youth offense before around age 17, whereas for girls, that is almost 20%. But one important finding is for those that have substantiation, represented by the blue lines, as well as notification but not substantiated, which is represented by the black line, they are quite similar. And the other findings is also the green, which is no contact before age 10, is represented by the green line. So these cumulative incidents provide a visual understanding of what is the absolute risk. But in terms of relative risk, how does the different levels compare to the control group, which is the no contact? The relative risk enables us to investigate. For example, we know that for girls, if they have been out of home care by the age 11, boys with any record in the out of home care are 13.7 times the risk, whereas for girls, the risk is 27.6. So this will provide a relative risk over time. So the other exposure is the timing and level, where N represent notification that not substantiated and S represent those that have been substantiated. So where we have whether it's notification at both timing or substantiation at both timing. And again, the cumulative incidence revealed that in terms of absolute risk, the absolute risk for boys are those that have substantiated at both timing, and girls is for those that have both substantiated and notification as well. So this also provides the sense of relative risk over time. So for by age 11, boys that have notification only in the first 5 years and substantiated from 5 to 9 are almost 21 times more likely to have youth offense. So the implication, there are 4 major implications. First is the high level provide opportunity for early prevention. And the second, as illustrated by the graph just now, those children with unsubstantiated notification have similar risk with those that have substantiated notification. And third, the importance of interagency collaboration. And fourth, the need for greater, broader public health initiative. So first, where will we go next? First, we understand the issue by future study that we have predictive model. And also, there might be children that have multiple outcomes such as self-harm, assault, and as well as poor school attendance. So we need we will be using the linked data set to investigate this research question. So in the view that we can hope to inform future policy as well as future evaluation using the linked data set. Thanks. I have reached the end of my presentation. Thanks.
Right. Thank you so much for that presentation, Vincent. That's most interesting. So now we have Gabrielle, and don't forget to put your questions in the Q&A. We'll come to shortly. So now we have Gabrielle Davie from the University of Otago, and she'll be talking to us about child protection inequalities in New Zealand, exploring the relationship with social gradient. Thank you, Gabrielle.
Thank you, Leonie. Kia ora. I'm going to speak about research we have undertaken exploring the relationship between the child protection system contact and social gradient. This research involved Associate Professor Emily Cadell, a social scientist with a practice background in child protection social work, and Dave Barson, whose expertise is in data management. My training's as a biostatistician, and I have a particular interest in the use of administrative health data. Before I start, I'll just set the scene. So I'm talking to you now from Dunedin, which is the city where the University of Otago has its main campus. In New Zealand, it's now almost 11 p.m, so apologies if I yawn. As a bit of background, unfortunately, many children internationally have contact with child protection systems. There's growing evidence, particularly from the UK, that indicates that the population in contact with CPS is not representative, but rather socially stratified. Deprivation has been identified as the major explanatory factor in the large differences between local authorities in England in the proportion of looked after children. As it had not yet been studied in New Zealand, we undertook this project to explore the size and the nature of this relationship between CPS contact and deprivation. Our specific research questions were: what are the relationships between social inequalities and the various decision points in New Zealand's child protection system? And does a social gradient exist in this relationship? This research was based on data in StatsNZ's integrated data infrastructure. The IDI is a large, or it's sometimes called the IDI. The IDI is a large research database that holds microdata about people and households. The population level data comes from government agencies, Stats New Zealand surveys, and in non-government organisations. If you want to know more about this data platform, there are a few presentations in the Conference On Demand library that are on the IDI, including an overview, and information is obviously available on the StatsNZ website. After the data has been linked by StatsNZ, it's anonymised for researchers. It is from this anonymised person level data that we obtained our population-based cohort of New Zealand children. So there were close to 1,017,000 children estimated to be living in New Zealand in the mid-2014. Hang on, I'm just... Of these, 1.8% had a record indicating one of 3 child protection system outcomes of interest. NZDEP was available for most of the data set, so the cohort used for analysis contained over 1 million children. The right of this slide highlights the magnitude of the potential bias in our results. 2,500 children who had a CPS outcome of interest were not found in the IDI's estimated resident population. Some may have moved overseas, but the majority are likely to be unable to be identified due to poor quality recording of name and address information, impacting on the likelihood of a match using probabilistic linkage methods. Now, NZDEP is the measure that we use for deprivation. This is based on 9 census variables, and it is used to assign a deprivation decile to a small area. In New Zealand, the smallest area that was in use at this time was the mesh block, and that contains roughly about 60 to 100 people. So the deciles are ranked using data from the census, and a 1 is the score given to the decile of small areas with the lowest deprivation, and a 10 to areas with the highest deprivation. So from the denominator data, we can see that 14% of children live in the most deprived decile. Children living in this decile are overrepresented in the CPS outcomes, with 36% of children who had at least 1 substantiation, 39% who had at least 1, and FGC stands for Family Group Conference, and 29% of children with at least 1 placement were living in the small areas considered to be the most deprived. This figure presents the rates of CPS contact per 100,000 children, and there's a clear pattern of increasing rates mirroring increasing deprivation. So substantiation, the blue line is the least severe of the outcomes, with actually the increase in rate not being as obvious with the most severe outcome. But I think you'd all agree there's a strong social gradient of contact with the child protection system at all points of contact. In terms of a relative difference, children in the most deprived quintile, so we've combined the deciles 9 and 10, have on average 13 times the rate of substantiation than children in the least deprived quintile, 18 times the rate of having a family group conference held, and 6 times the rate of being placed out of their family's care. In conclusion, we observed a marked relationship between the small area level deprivation and contact with New Zealand's child protection system. There's a clear need to address the causes of deprivation, provide services that respond to families living in poverty, and to examine carefully the interactions between demand and supply of services across the deprivation levels. And just noting here that but it is a limitation that 12% of those recorded as having a CPS outcome of interest were not able to be linked to the IDI estimated resident population. If you want to find out more about this research, I suggest reading our article that was published in Children and Youth Services Review, or sending me an email. Now, after presenting results from the IDI, we're obliged to present this disclaimer provided by Stats NZ. I'm not going to read it to you. Basically, it says that the findings presented here are those of the authors, not of Stats NZ or any other agency that's provided data to the IDI. In closing, I'd like to acknowledge my colleague Rebecca Lilly, the University of Otago, and the data providers, Stats NZ and Oranga Tamariki, which is the Ministry for Children. I would also like to acknowledge the Virtual Health Information Network that supports high value and high quality research from linked data, particularly that using the IDI by creating easily accessible resources and supporting open sharing of code and resources. Thanks for listening.
Great. Thank you so much for that, Gabrielle. We're very nice selection of papers we've got here that are providing some quite different, covering different areas, but obviously a lot of information that will be of interest. We now move to Sharon Williams from the Victorian Department of Health and Human Services, and she's going to be talking about transition from out-of-home care to adulthood, using linked data to look at the Compass Social Impact Bond. Thank you, Sharon.
Is that appeared, my screen share? I can't actually see it here. It doesn't seem to have appeared. Can you actually see the? You can see it. Okay, great. I'll get going there. So thanks very much for that introduction, Leonie. And I'm talking today about the Compass Social Impact Bond. I'll start by providing some information about the Compass program. So the Compass program's aimed at young people who have been through the child protection system and have been placed in out-of-home care. And once they reach age 18, they're discharged from out-of-home care and need to sort of face the challenges of life by themselves. So the aim of Compass is to progressively support 200 young people to transition from out-of-home care to adulthood. And it does that by providing access to housing and individualised support. So Compass is a partnership between Victorian government, not-for-profit organisations and investors. It was launched in 2018 after attracting $14.2 million from investors. So when we're talking about a social impact bond, what that means is an outcome-based model of commissioning services. So rather than paying for throughput, government pays for achievement of measurable outcomes. Investors fund some of the program costs, and then their returns are in turn funded by government avoided costs. So the assumption is that the successful completion of the Compass program means that those young people are less likely to use government services into the future. So there's a visualisation of the social impact bond process. So you see there that government investors both fund some of the program costs and to a special purpose entity, in this case Compass, and then service providers provide the service to the target cohort, in this case young care leavers, and the successful completion results in improved outcomes for the target cohort and society, and investors get some returns there. So Compass was designed specifically as part of the Victorian Government's first round of social impact bonds, and linked data has been central to Compass design and implementation. And there's 4 main ways in which this has been the case. So firstly, understanding the cohort of young people leaving out of home care. So we're fortunate at the time the Compass design started that the first version of the Victorian linkage map had been developed. We're linking together 20+ health and human services data sets with births and deaths data, and we were able to use that to look at the service use of young people who'd left out of home care, 2 large cohorts of several thousand each over a 10-year period. We looked at their service use within 3 years of leaving out of home care. Then in terms of design of Compass, a stratification model was developed to predict future risk of service usage to ensure a balanced mix of clients enrolled in the Compass service, so that it wouldn't be skewed too much towards those clients most likely to most at risk of high service use, or too much towards those at low risk of high service use. So payable outcome measures are the foundation of a social impact bond, and Compass has 3 payable outcome measures. The first one relates to housing, reducing the use of crisis housing. The second one's health, reducing emergency department attendances. The third one is justice, reducing criminal convictions. And then linked data is used to actually monitor the performance of the program against those payable outcome measures. So the outcomes for the program participants against those measures will be compared in the linked data with a matched comparison group also measured against those measures. So I'll talk briefly about each of those 4 aspects, starting with what we found from our analysis of the Victorian linkage map data, looking at that those large cohorts of out-of-home care leavers, where it was very evident the sort of challenges that they faced. So in terms of housing, nearly a third of the care leavers were identified as homeless, and care leavers were overrepresented in public housing, indicating a challenge in finding housing in the private market. In terms of health, nearly 80% had experienced at least 1 hospital admission, with females having on average 7 admissions and males nearly 5. 75% had at least 1 emergency department presentation, and 26% had 5 or more, with injuries or poisonings accounting for 32%. Over 50% had used acute mental health services, and 32% alcohol and drug services. Use of these services was higher for young people leaving residential care rather than other forms of family-based care. In terms of justice, around 75% of care leavers appeared in police data, and 25% in youth justice or adult corrections, and boys were much more likely than girls to be found in youth justice. So moving on to the stratification model that was developed as part of the design, that used the linked data to understand risks of future service usage based on history and demographics. So the analysis was quite similar to that cohort analysis, but it was actually a larger cohort right back to 1995, and a narrower range of services that focused on those services we'd already decided at that stage would be represented in the payable outcome measures. So the model was based on a mix of regression modelling across those domains, and then collapsed into one rating of high, medium and low. And we actually have a tool that that was operationalised, the modelling into a stratification tool that Centre for Victorian Data Linkage uses to calculate the complexity rating of high, medium or low for each young person who's eligible for entry to the program. So I should point out there that it's only that stratification process is only used to understand the overall mix of young people entering the program, and the actual service responses are individualised for each of the young people. They're not based on that stratification tool. So in terms of monitoring performance for payment purposes, we need to monitor outcomes for Compass participants against the 3 payable outcome measures, and we need to do that for several years past the completion of the Compass intervention to see what impact it's actually had on that the young people's lives. So we need a robust evaluation technique, as investor payments are dependent on outcomes, and some possible techniques like surveys, for example, they can be problematic with transient and vulnerable populations in terms of being able to retain the sample. So the approach that was decided on, and this was by negotiation between all the parties, the government and the service provider, was that outcomes for program participants would be compared against compared against a matched comparison group identified in the linked data according to each of those payable outcome measures. So that involves obviously using statistical techniques to generate a comparison group as similar as possible in observed characteristics to the intervention group, but one that hasn't participated obviously in the Compass program and or any other similar program. And the relative performance of the intervention and comparison groups will be measured at agreed intervals over several years. And as part of the sort of ensuring that all the processes are carried out in, it will be appropriately, it will be confirmed by an independent certifier. So where we've just sort of recently got up to was selecting the actual matching method, and there's many techniques for selecting a matched comparison group, but no standardised guidelines for selecting the most appropriate model. And in this instance, we need to select a technique that's fair to investors and also to government, and it was agreed. So the Victorian government did this work, but it was agreed that it would be subject to independent expert review. So the approach we took was selecting a historic group of random individuals from the linked data, and we evaluated several matching techniques using Monte Carlo simulation and identified a preferred matching method of propensity score matching, where the propensity score is generated by logistic regression. We found that had the lowest bias and variance. It's got a couple of conditions. Each control can only be matched to one treatment client, and each match must be within the same stratification level, so that high, medium and low that we were talking about. So that's basically as far as we haven't actually really got into the measurement side of Compass yet, but we've already learned quite a few lessons from where we've got to so far. And certainly that initial analysis, cohort analysis, that was very valuable in understanding the cohort for planning the intervention, but has also been more broadly valuable in use by government for other purposes with this cohort. But because there's a long lead time between design and implementation, we found that data requirements and assumptions need to be really documented in detail at the design phase, so that there's as much clarity as possible when we actually get to the implementation stage. And detailed testing of specifications, calculations and processes is critical to make sure that they work in that real world environment. So we think that Compass SIB provides a model for robust outcome measurement, and certainly Victorian government would like to use outcome measurement more broadly across service delivery, but we found it very resource intensive the resource-intensive nature of the linkage and analysis may well limited the scalability and broad applicability of this type of approach. We've also found, having just sort of identified the control group approach, there's because government is constantly introducing new programs for this particular sort of high needs group, and it's becoming more difficult to find sort of control subjects who haven't been subject to haven't been involved or won't be involved in a similar program. So that is something of a challenge. So yes, so that's the end of the presentation.
Thank you so much, Sharon. Now I need to see if I can find where we are with Q&A. Let me see. Some questions. There's just a question about how substantiation was defined. I think that would be probably for Gabrielle. I think you were, oh no, sorry. Yes, I think you were using substantiation in your presentation.
Yeah, I did. Sorry, I realised when I was going through that one of my slides wasn't showing, and I had accidentally hidden that slide. So we did jump a slide that did define a number of measures. Substantiation, they are the first, well, actually the first step on the process is actually notification. Substantiations is the next step, and those decisions are known to be variable because they rely on the subjective interpretive processes of the individual social workers. But they are a key point of system contact because they indicate the point at which increased intervention is likely to follow. So it's an event that has been notified to Oranga Tamariki, and from which they have been able to identify some form of proof. The family group conferences are kind of as a bit more in the name, that it's a meeting held to work together with the officials and the family to try and make progress.
Okay, thank you. That's helpful for people who aren't so familiar with the child protection space. I mean, in fact, there's, and I suppose Vincent might talk to that as well when you're looking at different levels of child protection involvement in terms of the sort of investigation and substantiation. There's quite a bit of controversy about whether they are really very different or not. I don't know if anyone else wants to comment on using those sorts of categories and how robust they are to identify sort of level of potential harm.
I would probably mention about the usefulness of even notification that are not substantiated. I think that in this, it depends on how this link data is being used. And in our study, the outcome is youth offending that happened after age 10. So if the government want to have some early intervention to prevent sort of youth offending, then the contact with child protection, even if they are not substantiated, they are just notification, will probably be useful in the government in targeting the programs that sort of help to prevent contact with the youth justice. So there, of course, there might be some notification that are not substantiated, but not necessarily indicator of harm, but at least it provide a sense of proxy for some intervention or supporting program that is needed for these children.
Thank you. Sharon, there's, in fact, there's a number of people who've said sort of thank you for the presentations. Sharon, there's a question there about the level of investment in the program. And I noticed at the beginning you mentioned there was $14 million, and I think you said 200, a target of 200 young people, which works out at something like 70,000 per person. So just sort of taking that a bit further, is that level of investment, was that based on an estimate of potential cost saving or an estimate of what they thought a program would cost? Do you know how the actual investment was established?
Well, certainly it's based on sort of the sort of underpinning of the social impact investment is that it's based on avoidable costs to government in the future. So that I think in the first slide I said that a positive outcome for the young person means that they're much less likely to use services into the government services into the future, and that can be quite a long way into the future. So it can involve quite high numbers of the high amounts of avoided costs. But yes, there was a lot of sort of financial modelling that went into the to working out. So it's partly based on the cost that's required to deliver the service, but there's a lot of financial modelling that goes into the sort of the level of avoided costs over time as well.
Thank you. There's a question here for Gabrielle, asking about whether you can link data on the parents, so I know more about the what do you have on the parents in terms of their, particularly their child protection involvement, given there's sort of quite a lot of evidence around parental child protection involvement, then an ongoing link to poverty and disadvantage, and then child protection involvement of the child. So it seems to me, I suppose part of that question is also around the whole sort of causal link and the direction of causality, and particularly the intergenerational element of that. So part of it's potentially a data linkage question, but also there's some questions around the underpinning theory and logic of the research.
There's a couple of questions there. In terms of the data linkage, yes, the IDI is it's a population level data set from which you can link using, I guess, both the birth information that's recorded by the Department of Internal Affairs on the birth certificates as to who the child was and who the parents are, but also through and combined with also the census information that would be able to tell you who is living in a house at a certain on census night. You'd be able to link. It takes a bit more data management obviously involved with linking up parents and children, but it would be possible. And then from there you could access information about the parents, say from the range of other administrative data sets, so health or education or justice. The thing to note with the deprivation measure, in which it's where it gets harder with in terms of causality, is it is a small area level deprivation measure. It's not an individual level measure. So it does, yeah. I mean, even though you are talking, or in a city, you'll be talking about a couple of blocks. Yeah, there is still obviously variation within a small area as to levels of deprivation.
Right. So I think the question about causality isn't to do with the level of measurement, it's to do with the direction. So is it about, I mean, it seems to me there's an assumption that is it about disadvantage resulting in child protection involvement or child protection involvement intergenerationally, which is driving disadvantage. So it's a theoretical question, not about the area level of your data. Right.
Yeah, that's not something that we looked at, but I agree it would be fascinating to look at with this, and it is possible to do.
Okay. Rachel, there's a question here. Did I understand that SLAM carried out the DL?
I think
have a dedicated
data linkage.
Data linkage, okay. Just trying to make sure, and Yeah, I presume you understand the question.
Yeah. So yes, they have a dedicated data linkage centre called the Clinical Data Linkage Service, and actually they've linked a really wide range of different data sets. So we're kind of like the latest in a lot of different linkages that they've established. So for example, obviously there's a lot of evidence kind of over the recent years being generated in terms of physical health for people who have mental health conditions, and so they've linked hospital data in England to the mental health service user records. They've also linked data on mortality, so to be able to look at who and how people die who are using the mental health services. And there's some hope in the future that we could extend this linkage to include specifically data on birth records, and so hospital birth records into this linkage. So because obviously there's, I think, an estimated 1 in 4 women will return to court for a subsequent set of care proceedings, and those are typically women returning with infants, often newborn infants, and very quickly, so with very little time in between to kind of address those underlying issues that led to the initial set of care proceedings. And so kind of a key question for us is, does increased spacing of pregnancy reduce your risk of returning to court? Because of course we don't know, for the people who don't return to court, if they're having subsequent births and having good outcomes. So there's a real gap in the evidence there.
Yeah. A question here for Sharon. What do you think will be the first lot of outcomes that are going to be observed from the COMPASS intervention?
What do I think, or sorry?
Yes, I think in terms of, I suppose, you know, I mean, part of the issue with these impact bonds is the sort of the returns that one needs to see, and how quickly you think some of that will be observed.
Well, the measurement, the formal measurement process starts next year. So we're working towards that at the moment. So I think that's really when the initial outcomes will start to be seen. So we've sort of tested out the measures to some extent, but we haven't had the control group process fully. I mean, that's something that we've just recently done in terms of sort of testing the approaches, etc. So it's really going to start the measurement in earnest next year.
Can I actually ask, you said that there was going to be one control for each case. Why would you just have one rather than,
yeah, well,
one is far too few, particularly when you're looking at these sort of costs where you have huge variability.
Yes, I mean, I think that's a good question, and you know, as I said, the method. So, you know, that control group methodology was reviewed by an independent sort of reviewer to make sure that it was valid. But I think, you know, that is a risk if the you know, if we can't then find the one matched person or whatever. So I think yes, that certainly sort of needs to be. But I mean, in terms of your answer, why? Well, I understand, and it wasn't me who did that part of the work. It was one of the other people who sort of was involved in the presentation, but that was considered, you know, to be the most sort of accurate way of being able to measure the participants' progress. But and you know, that was agreed by the independent expert, but it does obviously bring some risks as well.
Yeah, I mean, yes, one could always, at any point, presumably increase your control group.
Yes.
Yes, and a question here for Gabrielle. Can you please tell us a little bit about VHIN?
Yeah. The VHIN is a virtual health information network. It's basically a network of New Zealand researchers, analysts, and professionals who have an interest in or are using health information, electronic health records, or the IDI. So there are guides on the webpage. I mean, it's New Zealand specific, but them so it contains guides through VHAN run training courses, are involved in an advocacy role. If you want to know more about it, there's quite a lot of information on the webpage, which is www.vhan.co.nz.
Thank you. Now, I'm not sure that we've got any more questions here, and I think we're pretty close to the end of the session. So if there's no more questions coming through, I'll thank. There were a few things that people put up, basically saying thank you for the presentations and that people have enjoyed the session. So I'll also add my thanks to the 4 presenters. And I think it's interesting how far data linkage has come in the last sort of decade, and there's so many very exciting projects out there. Even though it's quite challenging and time consuming, I think it's helping us to analyse public policy and also inform public policy. So thank everybody for their contribution.